when you picture a healthy, like a highly functioning human brain, it is so tempting to imagine it as this perfectly orchestrated symphony. Every single instrument playing its part in absolute perfect harmony.
Right, which sounds beautiful, but it's completely wrong.
Yeah, exactly. Because if you actually look at the electrical activity of a waking brain, it is much closer to like the static on a broken television set.
Yeah, it's a total mess.
It's a cacophony. You have billions of neurons, and they're all firing independently, having their own little isolated, whispered conversations.
And that desynchronized noise, that static,
Yeah.
is the literal sound of your independence.
Wow, okay.
Yeah, I mean, the fact that your neurons are firing out of step with one another is exactly what allows you to, process different thoughts or move your arm while listening to a sound.
Yeah.
It's what allows you to fundamentally be you.
But then, in the blink of an eye, that chaotic static can just change.
It can, drastically.
Imagine you are standing in the middle of a massive, noisy stadium. Everyone is talking over each other, ordering hot dogs, cheering, booing. And then suddenly, without warning, the entire crowd just stops talking.
Total silence.
Right. And they all turn to face the center, and they start clapping in this terrifying, perfectly synchronized lockstep. That sudden, overwhelming lockstep. That is what a seizure looks like at the cellular level.
That's a really great way to visualize it.
Thanks. Welcome to this deep dive. Today, we're taking a stack of medical history, neurological research, and cellular biology to really deconstruct the electrical storms in the human brain.
We've got a lot of ground to cover.
We really do. We aren't just going to look at what a seizure looks like from the outside. We are going deep into the invisible, microscopic tug of war that actually causes it.
And to really deconstruct these electrical storms, we need to establish a firm baseline. We need to define the storm itself.
Right. So where do we start with the definition?
Well, in 2005, the International League Against Epilepsy, the ILAE, they were led by a neurologist named Robert Fisher. They released this global consensus definition of a seizure.
Okay.
And it essentially boils down to three absolutely vital words. A seizure is a transient episode of signs or symptoms caused by abnormal, excessive, and synchronous neuronal activity.
Okay. I want to break down those three words because I feel like every single one of them is doing heavy lifting here.
Oh, absolutely.
So transient, that means it has a strict beginning and an end. It's temporary.
Right, exactly.
Which separates a seizure from, say, a stroke or like a chronic brain condition where the damage is just fixed. A seizure starts and then it stops.
Exactly. And then you have excessive, which points to the fact that we're dealing with too much electrical activity.
Right, not a deficit. It's not a dimming of the lights.
No, it's a surge. But synchronous, that feels like the real key to me.
Because going back to that stadium analogy, the defining problem isn't just that the neurons are overly active. It's that huge populations of them lose their individuality.
They lose the static.
Right. They start firing together in this massive, overwhelming wave.
And that loss of individuality is the core mechanical failure here. And, it helps to draw a hard line between two terms that people they just use interchangeably all the time, which are a seizure versus epilepsy.
Yeah, I'm guilty of doing that myself.
Most people are. But a seizure is a single event. It is the electrical storm itself. Epilepsy, on the other hand, is the enduring climate.
The climate. Okay, I like that distinction.
Right, it's the underlying persistent tendency of a brain to have recurrent, unprovoked seizures over time.
So just to clarify for everyone listening, someone could have a single seizure because, I don't know, their blood sugar plummeted to dangerous levels.
Exactly. Or they had a wildly high fever, or they suffered a really severe blow to the head.
So the brain was provoked into a storm.
Yes.
But that does not mean they have the climate of epilepsy.
Precisely. And historically, diagnosing that climate required doctors to basically wait for lightning to strike twice.
Which sounds incredibly dangerous.
It was. For most of the 20th century, the golden rule was that a patient had to suffer 2 or more unprovoked seizures, and they had to be spaced more than 24 hours apart to officially get an epilepsy diagnosis.
But then there was a massive shift, right? Like, recently.
Yeah, in 2014, the ILA finally updated that definition. They declared that a doctor can diagnose epilepsy after just one single seizure.
Wow, just one.
Just one, provided the patient has a 60% or higher risk of having a second one.
Okay, but if you're wondering how this actually changes a patient's life in the real world, because, changing the wording in a medical dictionary might sound purely academic.
Oh, it's not academic at all. It completely alters the trajectory of care.
Right, it fundamentally changes lives. Because imagine a scenario where a patient has their first seizure, right? They're terrified. They go to the hospital and an MRI reveals, say, a brain tumor.
Or an EEG shows a highly specific abnormal electrical pattern.
Right. So the neurology team knows, without a doubt, that the risk of a second seizure is enormous.
But under the old pre-2014 rules, those doctors couldn't officially diagnose epilepsy yet.
Which is crazy. That meant the patient couldn't access specific targeted treatments or apply for crucial disability benefits.
Exactly. And they were trapped in this awful regulatory limbo regarding their ability to drive or go to work.
They were essentially being told, we know you're in danger, but we need you to go home and suffer a potentially life-threatening second event before we can actually step in and help.
Which is just a terrible waiting game. But the 2014 shift abandoned that. It allowed clinicians to treat the climate before the second storm hit.
That makes so much more sense. But to understand how we even arrived at this modern, highly precise electrical understanding of the brain, we kind of have to look backward.
You do.
Because humanity profoundly misunderstood this condition for millennia. Like, epilepsy is one of the oldest documented medical conditions on Earth.
Oh, absolutely.
There's this Babylonian medical text from over 3,000 years ago, the Sekikru tablet, and it vividly describes seizure episodes. But they didn't see an electrical storm.
No, they thought it was demons.
Yeah, a demon named Antisupa.
Right, because the ancient world almost universally looked to the supernatural to explain the unexplainable. For centuries, a seizure was defined strictly by what it looked like on the outside.
The sudden convulsions, the foaming at the mouth, the, dramatic loss of consciousness.
And because that physical manifestation was so violent and just unpredictable, it was interpreted as divine punishment or demonic possession.
Even though Hippocrates, way back around 400 BCE, he wrote an entire treatise called On the Sacred Disease, and he essentially laid out a biological argument.
He was really ahead of his time.
He was. He stated that this condition was not caused by angry gods or demons, but by an affliction of the brain itself. He was practically shouting that it was a physical disease.
But society completely ignored him for over 2,000 years.
2,000 years? Why?
Because the supernatural explanation just felt more aligned with the terrifying visual reality of a convulsion. Society preferred the myth to the messy biology.
That's wild. So when did things actually change?
The true turning point didn't arrive until the 1860s in London, thanks to an English neurologist named John Healings Jackson.
Ah, John Healings Jackson.
Yeah, he's basically considered the father of the modern mechanistic definition of seizures. He pushed past the convulsions and started asking what was physically initiating them.
And he defined a seizure as an occasional, an excessive, and a disorderly discharge of nerve tissue.
Which is incredibly striking.
It is, because he essentially wrote the 2005 ILAE definition, just using Victorian English, and long before we had the technology to actually measure those electrical discharges.
Yeah, he rebelled against the prevailing medical dogma of his time. Back then, they thought epilepsy was just one monolithic disease or some vague irritation of the body's humors.
Right, the humors.
But Jackson insisted that seizures were localized events. He believed that by closely watching how a seizure physically played out in a patient's body, a doctor could reverse engineer exactly where the electrical storm started.
Just by watching it spread.
Exactly. He mapped how it spread through the physical tissue of the brain.
And this concept is immortalized as the Jacksonian March, right?
Yes.
Where Jackson observed patients whose seizures would start as just a tiny involuntary twitch in one finger. And then, over a matter of seconds or minutes, that twitch would march up the hand, into the forearm, up the shoulder, and finally into the muscles of the face.
It's like watching a city's power grid fail block by block.
Yes. You see the lights go out on one street, then the next neighborhood, and the next. By watching that sequence, you can trace the exact path of the failure.
And Jackson realized that the brain's geography was mapped directly to the body. He was mapping the motor cortex decades before MRI machines or modern brain scans were even a concept.
It really is a masterclass in observational medicine.
It truly is. And Jackson's theories built the foundation for Wilder Penfield.
The Canadian neurosurgeon, right?
Yeah, he worked from the 1930s through the 1950s. Penfield took Jackson's theoretical map and literally opened it up to test it.
Which is fascinating.
He performed brain surgeries on patients who had severe, untreatable epilepsy.
And he did this while the patients were fully awake, which sounds like something out of a horror movie, honestly.
I know it does. But the brain tissue itself doesn't actually have pain receptors.
That's right. So after numbing the scalp, the patients were awake, alert, and just talking to him while he worked on their exposed brains.
Yeah. And his primary goal was to find the specific focus, the bad patch of malfunctioning brain tissue that was generating the seizures.
So he could surgically remove it.
Right. But he had to do it without destroying the critical areas needed for speech or movement. So to do this safely, he used a weak electrical probe to stimulate the surface of the brain, and he just asked the patient what they felt.
And in doing so, he mapped the human homunculus, like the physical representation of the sensory and motor systems across the brain's surface.
Exactly. He would poke 1 millimeter of tissue, and the patient's thumb would tingle.
Then he'd move the probe just a fraction of an inch, and their upper lip would twitch.
But the most profound discoveries happened when he stimulated the temporal lobe. Patients wouldn't just experience a muscle twitch. They would suddenly report smelling burning toast.
Wait, really? Just from a probe?
Yeah. Or they would be struck by a massive, overwhelming wave of déjà vu. Or they would vividly, perfectly relive a specific memory from their childhood.
That is incredible.
Penfield proved that the seizure focus wasn't just a diseased spot. Stimulating it offered a literal window into how normal human memory and sensory function are organized.
So Penfield gave us this incredible macro map of the brain. He showed us the continents and the borders, basically.
Right. The big picture.
But if we zoom all the way in, like past the lobes, down to a single microscopic cell, there has to be a physical trigger that tips a normal neuron into this synchronized lockstep.
And to understand that microscopic trigger, you have to look at the cellular tug-of-war happening inside your head every second of your life.
Okay, lay it on me.
Whether a healthy neuron decides to fire its electrical signal or stay quiet depends on a constant, incredibly delicate balancing act. On one side, you have excitatory input, the chemical accelerator.
And this is primarily driven by a neurotransmitter called glutamate, right?
Exactly. And on the other side, you have inhibitory input, the chemical brakes. This is mostly driven by a neurotransmitter called GABA.
So glutamate hits the gas and GABA pumps the brakes. A healthy brain is just a constant modulation of those two pedals.
Yes, a seizure happens when that balance tips decisively toward the accelerator across a critical mass of cells all at once.
And thanks to modern microelectrodes, we can actually see this happen at the cellular level, right?
We can. Seizing neurons display a very distinctive abnormal electrical signature. It's known as the paroxysmal depolarization shift, or PDS.
So what does a cell actually look like when it's undergoing this PDS? Because a normal neuron just spikes, right? Like, it fires its signal, the voltage drops back down, and it resets immediately.
Right. But in a paroxysmal depolarization shift, the cell's membrane voltage lurches dramatically upward, and it doesn't reset. It gets stuck.
Stuck?
Yeah, it stays in this highly excited, depolarized state for an abnormally long time. And while it's stuck up there, it fires off a rapid machine gun burst of electrical spikes.
Wow.
And it does that before the brain's hyperpolarizing brake finally kicks in with enough force to drag the voltage back down to baseline.
So when enough neighboring neurons undergo this stuck machine gun burst at the exact same time, whether because there's a flood of glutamate or, the GABA brakes completely fail, they just recruit each other into this localized hypersynchronous way.
That's exactly it. And from there, it either stays contained in one area as a focal seizure, or it overwhelms the surrounding tissue and spreads across the entire brain.
Now wait, I need to challenge a concept here because this is where the cellular mechanics get incredibly counterintuitive to me.
Okay, what is it?
Well, we just established that a seizure is defined by excessive electricity. Too much firing. But if you look at a condition like Dravet syndrome, which is a severe childhood epilepsy, researchers discovered in 2001 that it's frequently caused by a mutation in a specific gene called SCN1A.
That's right.
And this gene makes sodium channels which help conduct electricity in the brain. But the twist is that the mutation is a loss of function mutation. The sodium channels are broken. They don't work.
Yep, they are broken.
So how does a broken electrical channel, which provides less function, lead to the excessive electricity of a seizure?
The brilliant part of that paradox is that it forces us to look at the architecture of the brain, not just the individual cells. It completely flipped the field's intuition when it was discovered.
Because it just sounds backwards.
It does.
Yeah.
But to solve the puzzle, you have to ask, exactly where are those broken sodium channels located?
Oh, I see.
In Dravet syndrome, the mutation primarily destroys the sodium channels on the brain's inhibitory interneurons, the specific cells that release GABA. Exactly, the brakes. The mutation is isolated on the brakes, not the accelerator. When those specific sodium channels fail, the inhibitory neurons physically cannot fire their signals. The braking system is completely disabled.
Wow. So the excitatory network, the glutamate-driven accelerator, is just left to run completely unchecked.
Unchecked, it proves that a genetic mutation doesn't have to make neurons directly hyperactive to cause a seizure. It just has to silence the cells, whose only job is to quiet things down.
It's exactly like cutting the brake lines on a car and wondering why it's careening out of control down a mountain.
That's a perfect analogy.
The engine didn't suddenly get more powerful. The stopping mechanism just simply vanished.
Right.
So if a single broken brake line can cause one crash, how does a brain go from having one isolated accident to becoming a permanent high-risk crash zone?
That transformation is a concept called epileptogenesis. And the clearest way to understand how a brain alters its own climate is through a landmark experiment from 1969 by a neuroscientist named Graham Goddard.
Tell me about Goddard's experiment.
Goddard was studying rats, and he surgically implanted a microscopic electrode into a rat's amygdala. He applied a tiny, nearly imperceptible electrical current. I mean, something so weak it couldn't possibly trigger a seizure on its own.
Just a tiny tickle of electricity.
Yes. And predictably, nothing happened. The rat was totally fine.
Okay, but he didn't stop there, did he?
No, he didn't. Goddard applied that exact same tiny electrical tickle again the next day, and the next. He just repeated that weak stimulation once a day.
And what happened?
Well, over days and weeks, the rat's neurological response began to amplify. Eventually, that exact same tiny current, which originally did absolutely nothing, produced a massive, full-blown convulsive seizure.
From the same tiny current.
Yes. Even more startling, after enough repetitions, the animals began having spontaneous seizures without any electrical stimulation from the electrode at all. This model is called kindling.
So the brain is essentially building a dark pathological form of muscle memory. Like, through repetition, the brain is actively learning to become more excitable. It's paving a dirt road into a superhighway for electrical storms.
Kindling is a terrifying demonstration of neuroplasticity. It proves that an epileptic brain isn't just statically broken. It actively adapts to become more efficient at seizing.
Which is a scary thought.
It is. But this highlights the crucial difference between ictogenesis, which is the initial spark that starts a single seizure, and epileptogenesis, which is the gradual underlying process of the brain lowering its own defenses and becoming permanently seizure-prone.
And the tragedy of modern neurology is that the drugs we have today, they only target ictogenesis.
Right. They only suppress the individual storms by artificially boosting GABA or blocking sodium channels. We do not yet have clinical drugs that can stop epileptogenesis.
We can't stop the underlying climate change in the brain.
Not yet.
So if the brain learns to seize, how do we actually stop it permanently? I know for a century, the medical field relied almost entirely on the focus theory, which goes straight back to Jackson and Penfield.
Right, the idea of finding the one bad patch of brain tissue, the focus, and surgically cutting it out.
But that's changing now.
Yeah, since the early 2000s, a rival framework has gained serious ground, which is the network theory.
And what does that say?
This theory argues that seizures, especially in brains where an MRI doesn't show a clear physical lesion like a tumor, they don't just have one single address. The abnormal electrical dynamics are distributed across a whole network of interconnected regions.
Okay, but if the network theory is right, that completely upends how we approach surgical cures. Because if you surgically remove one node of a disease network, the remaining nodes in the network can simply reorganize.
And continue generating the electrical storms. Exactly.
That's wild.
We are getting incredible real-time data on this network behavior from researchers like Catherine Chavon at Columbia University.
Oh, I read about her work.
Yeah, she uses remarkably dense microelectrode arrays, placing them directly onto the surface of the human brain during surgery. And her data proved that a seizure is not just a uniform, expanding tidal wave of hyperactivity crashing over the cortex.
It's highly structured. Like, Chavon's work revealed this intensely active ictal core, the epicenter of the storm.
Yes.
But surrounding that hyperactive core is a penumbra, a ring of tissue that is actually being violently suppressed by the brain's own inhibitory systems.
It is a microscopic, real-time battle line. The GABA brakes are slamming down with everything they have in that penumbra, trying to build a wall of inhibition to contain the hyperactive core.
It's a literal tug of war.
And sometimes the brain wins that local tug of war, keeping the seizure from generalizing, even as the storm rages in the center.
Because this brutal electrical battle happens completely invisibly inside the skull, Humanity has spent centuries filling the void of understanding with myths based purely on the physical outward symptoms.
So many myths.
And we really need to dismantle some of these misconceptions because they actually endanger people.
Let's do it.
First up, the idea that all seizures involve convulsing and falling down. In reality, many seizures involve absolutely no violent movement.
That's completely true.
Take childhood absence epilepsy, for example. A child might be mid-sentence, suddenly stop, stare blankly into space for like 5 to 10 seconds, and then just resume talking as if nothing happened.
And teachers often punish these kids for daydreaming, having absolutely no idea their brain is actively seizing.
The mechanism behind an absent seizure is fascinating, though, because it looks nothing like a convulsion on an EEG.
No, you don't see chaotic static at all. Instead, you see a strikingly regular, deeply synchronized 3-per-second rhythmic wave washing across the entire cortex.
And this highly organized rhythm is generated by the thalamocortical loop, right?
Exactly. Think of the thalamocortical loop as the brain's internal metronome. It is the exact same pacemaker circuitry that dictates our deep sleep rhythms.
So an absent seizure is essentially the brain's normal sleep circuitry being inappropriately tipped into a pathological waking rhythm.
Exactly that. And this rhythm is driven by a very specific type of electrical gate called a T-type calcium channel.
Which shows exactly why understanding the cellular mechanism matters so much.
Yes, because if you give a child with absent seizures a standard convulsive epilepsy drug, it often won't work, and it might even make it worse.
But if you give them ethosuximide, a medication designed to specifically seek out and lock those T-type calcium channels, the absent seizures stop beautifully. You have to target the specific mechanical failure.
Right. Let's hit another dangerous myth.
Okay, yeah. People swallow their tongue during a seizure.
No. It is anatomically impossible to swallow your own tongue. It is firmly attached to the floor of your mouth.
Right. But this myth is deadly because well-meaning bystanders have spent decades shoving wallets, spoons, and fingers into seizing people's mouths.
Which is so dangerous that it causes broken teeth, lacerations, and it actually blocks their airway.
Exactly. If someone is seizing, do not put anything in their mouth. Just cushion their head, roll them on their side, and time the event.
Another really pervasive myth is that every single seizure causes permanent brain damage.
That's not true.
For the vast majority of people, brief, uncomplicated seizures do not cause structural brain damage. The brain is remarkably resilient.
Good to know.
However, the real danger arises during a condition called status epilepticus, which is when a seizure lasts longer than 5 continuous minutes.
And this brings us back to glutamate, right? Our chemical accelerator.
Yes.
Why is a 5-minute seizure so dangerous? Because of excitotoxicity. When a seizure goes on that long, the neurons are releasing massive, unrelenting floods of glutamate.
It is essentially revving the engine of the neurons so hard and for so long without any oil that the cellular machinery literally burns itself out.
The neuron absorbs too much calcium, activates destructive enzymes, and dies. That is why a seizure lasting longer than 5 minutes is a medical emergency requiring immediate intervention.
Finally, we have to address the violence myth.
Oh, this one is important.
Popular culture frequently brings up Charles Whitman, the 1966 Texas tower shooter, because an autopsy found a tumor pressing against his amygdala. This has led to a narrative drawing a straight line from seizures in the temporal lobe to premeditated, purposeful violence.
It makes me incredibly angry because it just demonizes a neurological condition.
And the broader scientific consensus strongly rejects that straight line. The amygdala's role in human aggression is incredibly complex.
Right.
While a seizure might cause rare instances of physical thrashing, it is almost always undirected, confused flailing as the person tries to orient themselves.
A seizing brain is essentially offline. It is mechanically incapable of the organized, purposeful, premeditated planning required for targeted violence.
Exactly. Linking epilepsy to moral failing or targeted aggression is just a tragic misuse of neurological science.
Think about what all of this means for your own brain, though. Like, why should you care about GABA, glutamate, and Jacksonian marches? Because 50 million people worldwide are living with epilepsy.
Over the course of a lifetime, 1 in 100 people will develop it.
And it isn't just a condition you're born with, right? Like, the rates actually spike again in older adults due to the tissue damage caused by strokes and normal aging.
Understanding this cellular tug of war also explains the everyday seizure warnings you see in the world. Have you ever wondered how severe sleep deprivation or heavy alcohol withdrawal can trigger a sudden seizure in someone who doesn't even have epilepsy?
It all comes back to the brakes and the accelerator.
Yes. Alcohol is a central nervous system depressant. It artificially pumps the brain's GABA brakes. If someone drinks heavily and then suddenly stops, the brain is suddenly left with no artificial brakes, and the native GABA system is too suppressed to compensate.
The accelerator takes over completely and the brain storms.
It's all connected.
We have covered a massive amount of ground today. We started with ancient Babylonian demons and moved to John Hewlings Jackson, mapping the geography of the brain just by watching a single twitch march up an arm.
We covered a lot of history.
We really did. We explored the paradoxical broken brakes of Dravet syndrome, the dark muscle memory of kindling, and that live microscopic tug-of-war happening right at the edge of the seizures penumbra. We went from a stadium suddenly clapping in terrifying unison down to the microscopic gates that control the flow of human consciousness.
It is a profound marvel of biology, even when the mechanics fail. And I want to leave you with a final thought to mull over, building on Graham Goddard's kindling model.
Oh, I'm ready.
We know from kindling that neuroplasticity allows the brain to essentially learn how to have seizures through repeated electrical stimulation. It builds these pathological superhighways.
Right.
But neuroplasticity, the brain's incredible ability to rewire itself, works in both directions. If a brain can learn to seize, is it possible that future treatments could hijack that exact same neuroplasticity?
Wow, wait.
Could we eventually design a therapy that forces the brain to actively forget or unlearn these pathological pathways before the permanent climate of epilepsy ever sets in?
A cure that relies entirely on forcing the brain to forget. That is a profound question to end on. Thank you for joining us on this deep dive. Keep questioning the world around you, and we'll catch you next time.